Dear colleagues, in partnership with Nephrology Dialysis Transplantation, NDT, the official journal of the European Renal Association, MARKUS at Home welcomes Dr. Olivier Aubert in Paris, France, and Dr. Aylin Akifova in Berlin, Germany, in order to discuss donor-derived cell-free DNA monitoring for diagnosing allograft rejection in kidney transplant recipients, which is the topic of a Nature Medicine paper by Dr. Aubert and an NDT paper by Dr. Akifova, which NDT's editor-in-chief, Dr. Anders, Andreas Kronbichler, and I picked as our NDT paper of the month. Dear Dr. Akifova, dear Dr. Aubert, we're very happy to host you for our pre-final stage of our Tour Académique 2025. The cyclists still have to climb the Mont Ventoux and the Alps. We are already in beautiful Paris. Thanks so much for joining us tonight.
Thanks, Gunnar. So, dear colleagues, today, very interesting things to discuss together. And our two speakers are Olivier Aubert. So, Olivier Aubert is MD, PhD. He's a nephrologist. He's an assistant professor of nephrology in Paris in the Necker Hospital. He's a member of the Paris Transplant Group. He's co-authored or authored over 100 papers in very prestigious journals. He has a broad expertise in kidney transplantation with a specific focus on the diagnosis of humoral rejection. This is, of course, an evolving field, and we're very happy to hearing on this topic. And just after Olivier's presentation, Aylin Akifova, who works in Charité Hospital in Berlin, will talk about the randomized control trial on cell-free donor-derived DNA in the diagnosis and the management of transplant rejection. So, Olivier, it's up to you. The floor is yours.
First, thank you very much for the invitation. Thank you for this introduction. And so, yes, here I'm going to talk about rejection and how we can use new biomarkers to detect rejection, but also for the diagnosis. And so first, when we talk about emerging biomarkers in transplantation, so we do have conventional biomarkers, and those works. So we have the DSA, we have the creatinine, the proteinuria, but also the viral screening. But what we need new biomarkers in order to detect rejection, but also to better make the diagnosis. And so for the non-invasive biomarkers, we have the chemokines in the urine, blood transcript, cell-free DNA, but also others. And so those biomarkers then can help you to make the diagnosis. But then when we perform the diagnosis, the biopsy, when we want to make a diagnosis, we have the transcriptomics. So we can use MMDX, nanostring, or tissue genomics. And I'm going to talk about the non-invasive biomarkers, but also the invasive biomarkers. And so why do we need new biomarkers? This is because we have limitations of the current biomarkers. First, for the patient and the disease, most of the biomarkers, they have low sensitivity, low specificity, and we very often need a biopsy. Then for the pathologies, as we know, we have sampling error, poor reproducibility, inter-observer variability. So for example, for most of the BAM scores, the kappa value between two pathologists is 0.5. But then also for the nephrologists, we don't have very good thresholds, and those biomarkers, they have a low prognostic capacity. So we do need new biomarkers on top of the biomarkers that we use all the time. And so how can we use it? Let's say, for example, for rejection, we have all the patient. We can divide the population into the patient at high risk of rejection. So let's say when they have DSA, and then at low risk of rejection when they don't have DSA. So then you want to focus on the population at high risk. And this is when you want to use new biomarker to detect rejection. So using those biomarkers, you can perform the biopsy earlier, and then you can make the diagnosis earlier of rejection, and you can treat the patient. But then when the diagnosis is complicated, then you can use a transcriptomics and those invasive biomarkers that can help you to better make the diagnosis. And so I'm going to talk with the non-invasive biomarkers to detect rejection, and I'm going to focus on the chemokines in the urine, but also donor-derived cell-free DNA. And so why? Because we have many publications on many biomarkers, but here you can see that the biomarkers that we do use in France are the chemokines in the urine and donor-derived cell-free DNA. So I'm not going to say that those biomarkers are the best, but this is the biomarkers that we use in clinical practice. And so first, the chemokines in the urine and the donor-derived cell-free DNA. So here, when you look at the chemokines in the urine, so I'm going to show you that it's associated with rejection, but those biomarkers are not very specific of rejection. So those biomarkers, they show you that you have inflammation in the kidney. So it can be elevated in case of BK virus-associated nephropathy, but also when you have infection. But in this publication, you can see that when you have rejection, so it can be pure ABMR, mixed rejection or TCMR, you can see that CXCL9 and CXCL10, they are increased. And when you look at the AUC, so this is a univariate analysis, so you can see that we have very good AUC, very close to 0.8, so a good discrimination. But then the same team, in this publication, they looked at the association of the chemokines with rejection, but also the added value. And so when you look at the table, you have the multivariable model with all the variables that are associated with rejection. And you can see that we can find the EGFR and also the GSS, so this is well known. But then on top of that, the chemokines, they are both independently associated with rejection. And then when you look at the added value, you have the black curve, which corresponds to the AUC of the model without the chemokines. So you have the GSA, the EGFR, and all the variables that we use to detect rejection. And then when you look at the blue curve, when you have the addition of the chemokines, you have a better AUC. It goes from 0.77 to 0.85. So there is an added value, and it's also associated with a good calibration. So the chemokines, they have a good performance to detect rejection with an added value. And so this is a biomarker that we use in clinical practice. But there is also another non-invasive biomarker, which is the donor-derived cell-free DNA. So this is a small part of DNA that you can detect in the blood. And so if you have the DNA from the donor, so it means that maybe there is inflammation in the kidney, so rejection, and this is how you can better detect rejection. And so in this publication from 2017, so they looked at the association of cell-free DNA with rejection, and you can see that the donor-derived cell-free DNA was elevated in case of rejection, and which wasn't the case for the creatinine. So what they said is like, if you use a cutoff of 1%, you have a very good specificity, so 85%. So using cell-free DNA can help you to detect rejection. Then this other publication in 2022, they made the same analysis, and they found a very good AUC for donor-derived cell-free DNA to detect rejection. So it was very close to 0.80. And you can see that cell-free DNA was elevated in case of rejection and very low when you don't have rejection. And they showed also that there is no association between creatinine and rejection. So based on those results, donor-derived cell-free DNA has been reimbursed in the US, and so they can use it. But it wasn't used in France. And so what we did, we looked at the association of cell-free DNA with rejection. But we didn't want to just include the normal biopsies versus the rejection. So we included all the biopsies that we performed in my center. And as you can see here, cell-free DNA was only elevated in case of activity. So when you have rejection, so when you have AMR, TCMR, but also mixed rejection. But cell-free DNA remained very low when you have no specific lesions, fibrosis, just borderline lesions, or glomerulitis without rejection, or even when you have inactive AMR. So cell-free DNA was only associated with rejection. But then we wanted to look at the association of cell-free DNA with the severity of the disease. So we looked at the BAMF scores. And so here you can see on the top that you have the BAMF scores that are associated with the AMR. So you have glomerulitis, this is the GBAMF lesion, peritubular capillaritis, the PTC BAMF lesion, and also the C4D deposition. And you have the BAMF score going from 0 to 3. And as you can see, the higher is the lesion, the higher is cell-free DNA. So cell-free DNA seems also to be associated with the severity of AVMR. But it's also the case for the TCMR lesions. So this is the lesions in the bottom. You have the IBANF lesions, so inflammation. You have the tubulitis, TBANF lesion, but also total inflammation BANF lesion. And we can see the same results. The higher is the BAMF score, the higher is the cell-free DNA. So it seems that cell-free DNA is associated with rejection, but also with the severity of the disease. But here you just have descriptive analysis. And so we wanted to see if cell-free DNA was independently associated with rejection. So once again, when you look at the multivariable model, you can see all the variables that are independently associated with rejection. And this is well known. We have the GFR, proteinuria, kidney graft instability, previous episode of rejection, but also the GSA. And on top of that, you can see that donor-derived cell-free DNA was independently associated with rejection, so independently of all the variables that we use. But once again, when we have a new biomarker, even if it's independently associated with the outcome, it doesn't mean that it's very useful in clinical practice. So to show that, you need to show that there is an added value. And so this is the case here. This is very similar to the chemokines in the urine. So the blue curve corresponds to the model without donor-derived cell-free DNA. So you have the EGFR, you have the proteinuria, DSA, a previous episode of kidney rejection. And you can see here that the AUC is good, 0.77. So first, it means that when we want to detect rejection, we have good tools, good biomarkers. But then the red curve corresponds to the same model with the addition of cell-free DNA. And as you can see here, there is an added value. So the AUC goes from 0.77 to 0.82, and this is significant. And it was also the case in the validation cohort, including the US and also Belgium. So here we can see that cell-free DNA is independently associated with rejection, but also there is an added value. And so what we did an online application to predict rejection where we can enter all the variables and then you get a probability of rejection. But then I wanted to show you two cases where we use the cell-free DNA or the chemokines to make the biopsy. And you can see that those biomarkers were very useful, especially in case of a subclinical rejection. The first one is a woman, 58 years, no pre-existing DSA, a very stable creatinine between 80 and 100 micromole per liter. So at 3 months post-transplantation, we performed the biopsy. The biopsy was completely normal. At 1 year, very stable creatinine, no proteinuria, and no DSA. And so we performed the chemokines in the urine, and CXCL9 was elevated, so close to 1,000. So we just performed the biopsy based on the chemokines. And as you can see here, we were very surprised by the result. It was a severe TCMR, I3, T3, CPT2, V2, and also cortical necrosis. No sign of ABMR, just a C42, but it was an ABO incompatible. And so we treated the patient and now she recovered from rejection. But this is an example where the chemokines were very useful. Another case, a woman, 46 years, first transplantation in 2019. Once again, very stable creatinine, normal biopsies at 3 months and 1 year. She had a de novo DSA in 2022, but then it was very stable. And so part of the monitoring, because she had DSA, so we performed cell-free DNA, which was 1.58. So once again, we performed the biopsy only based on the results of donor-derived cell-free DNA. And as you can see on the pictures, you have peritubular capillaritis. You have then the G-score was 2, and then you can see C40 deposition. So in this case, it was rejection. Once again, we treated the patient. So you can see here that when you use the non-invasive biomarkers, you can better detect rejection, even for subclinical rejection. But sometimes when we perform the biopsy, it's very difficult to make the diagnosis, to differentiate TCMR, AMR, or mixed rejection, but also when you have borderline lesions. And so this is where you want to use the invasive biomarkers. And so we have many publications on the transcriptomics, and you can see it's increasing since 2000, and now we have more and more publication of transcriptomics. And then it was endorsed by the BAMF 2019 meeting, and we now have the meeting report that showed that the molecular diagnostic in solid organ transplantation, you can use the transcriptomics, and there is a consensus for the BAMF human organ transplant gene panel. And so I'm going to show you what is this gene panel. So you have 770 targeted genes, and those genes capture gene expression signatures associated with tissue injury, innate and adaptive immune responses, but also rejection. This is for the kidney mainly, but also for the lung transplant, liver transplant, and heart transplant. And so the idea was to create score to better make the diagnosis of AMR and also TCMR. And so when we need to use the molecular diagnosis, and so we have 8 prototypical situations where you should use it. Let's say, for example, you have microvascular inflammation, G plus PTC equal 1, C40 negative, DSA positive. So you don't have the clear diagnosis of AMR, so you can use the molecular diagnosis. Then also when you have borderline lesions, because you don't know if it's TCMR or just normal lesion with acute tubular injury, but also when you have, for example, PTC lesions, when you have TCMR, you don't know if it's just TCMR or mixed rejection. And so in those cases, it's difficult because it's different diagnoses, but also different treatments. And so what we did, we built a phenotyped reference set with all the biopsies of the patients. So we have 500 patients, 664 biopsies with all the BAMF scores and the diagnosis, but also the results of the gene expression. We divided into a development cohort, but also a validation cohort. And so in the development cohort, we had 669 biopsies with AMR, TCMR, normal biopsies, but also other lesions. And we divided the development cohort into a train set and also a test set. And so to show you what we did, we used the FFP biopsy, we performed RNA extraction, then we used the nanostring with the BHOT panel, and then we get a file where we can create the classifiers. And so I'm not going to go into the detail, but obviously you need to look at the quality of the data normalization, feature selection, then you perform the models, and then you can validate the model. And so here you can see the genes that were associated with AMR and TCMR, and there is no surprise. You have CXCL9, CXCL10, you also have CCL4. So those are the genes that are associated with AMR and TCMR. And so what we did a feature selection because we didn't want to keep all the genes. And as you can see here, we were able to identify 52 genes that were highly predictive of AMR and 15 genes that were highly predictive of TCMR. And so with those genes, we performed different models. So we use machine learning algorithms going from logistic regression to decision trees, random forest. And for each model, hyperparameters were optimized to have the best score that we can get. And we use the 7 different models, 7 different scores to just make one simple score with a prediction of rejection. And so just to show you here, so we have the probability of AMR and TCMR, and you have the different biopsies, and you can see that you have different scores, and the blue point corresponds to the median of all the scores. And so just how it works. So here you can see that we have the results for AMR and TCMR in France, US, and Canada. And if we look at the AUC, it was very good for the score for AMR, but also TCMR, very close to 0.90 in France, in the US, and also in Canada. So we were able to have very good score to make the diagnosis of rejection, AMR and TCMR. And so then we wanted to make a report to provide to different centers the results of the classifiers. And so when you have a biopsy, you can send the biopsy to our center, and then we can perform the nanostring, and then you get a molecular report. This is what we call the HistoMX in this report. So you have the probability, as you can see here, of AMR, TCMR, but also IFTA lesions. You also have the scores for the different BAM scores, and then you can project your patient into the reference set to see who are the neighbors that can help you to better make the diagnosis. And so I just have 2 cases to show you how it works. So this is the first case. So it's a patient with a de novo DSA, very stable kidney function, no sign of AMR or TCMR, but just a C42. And so we performed the nanostring. And here you can see the report. For this biopsy, the diagnosis was AMR with a high probability, 70%. And if you see the patient is clustering among active AMR. So based on the molecular score, this patient has evidence of AMR, and this patient was treated for AMR. The second case is a borderline lesion. So we had a patient with G0, PTC1, I2T1. So this is a borderline lesion. We don't know if it's a TCMR or a normal biopsy. We performed the molecular score. And as you can see here, high probability of TCMR, and the patient is clustering among the TCMR patients. And so here we had a very strong evidence of TCMR. And so you can see here that the molecular assessment of the biopsies that can help us to better make the diagnosis, maybe to better treat the patients. And so this is the end. So thank you very much for your attention.
Well, many thanks, Olivier. This was a fantastic presentation. We're going to straight away start with Aylin Akifova's presentation on her randomized control trial, and then we'll have the discussion together.
Thank you so much for your invitation and for the kind introduction. Also, thank you, Dr. Aubert, for your nice presentation on covering all the biomarkers. What I will be talking about today is a trial that we performed at Charité in Berlin. And we focused only on the impact of donor-derived cell-free DNA monitoring for early diagnosis of antibody-mediated rejection after kidney transplantation, which was a randomized trial. So I will move on to the background, and I will keep it short as Dr. Aubert already told you a lot about the overall performance of this biomarker. and which was mostly studied to detect allograft rejection after kidney transplantation. And I think we all have the impression, and what the literature is saying is that it shows the best performance in distinguishing the antibody-mediated rejection across all rejection phenotypes. And what we also know is that it correlates very well with the histological and molecular signs of APMR, which is the hallmark of it is the microvascular inflammation. However, what we know is also that there are not interventional trials about this biomarker, and no randomized trials, and maybe only few prospective studies that investigated the role of this biomarker. So we asked ourselves, what is the potential clinical implementation of cell-free DNA in the clinical practice, and how it can change the current diagnostic strategy, for example, in the selected cohort of kidney transplant recipients who has increased immunological risk as the evidence of donor-specific antibodies. So we tried to answer this complex question in a study that we conducted at Charité. This was a single-center study, and I will try to get you familiar with the study design and how we conducted all this, so we can discuss it later on. We selected 40 kidney transplant recipients who had a previous evidence of de novo DSA. And those were all patients who had a functioning kidney allograft with an eGFR above 20 mils. And all patients had to be at least 6 months after transplant. I think important inclusion or also exclusion criteria was that the patients had no diagnostic biopsy after the de novo DSA evidence, so they were at this formal risk for ABMR, but we didn't really know because we don't do protocol biopsies in our center. So we excluded patients, of course, with high bleeding risk and multi-organ transplantation. As we enrolled a patient in the study, we randomized them to either an intervention group, which was the cell-free DNA guided biopsy group, or to a control group, where basically the clinician had to guide the biopsy, and they would perform a biopsy if they think it is necessary, or the patients in this group received a protocol biopsy at the end of the study period if it wasn't indicated until then. What we did in the intervention group, and the intervention of the study, was to perform a biopsy whenever the cell-free DNA reached the cutoff of 50 copies per milliliter. And we did this irrespective of the creatinine or proteinuria status of the patient. And as you can see in the middle line, for both groups, we assessed the donor-derived cell-free DNA over 1 year at each outpatient clinic visit. And when performing a biopsy for most patients, we also had the chance to look at the molecular transcripts, and we performed it with the MMDX platform. Now, the whole primary endpoint of this investigation was to see if the cell-free DNA monitoring can reduce the time to ABMR diagnosis in the group which was guided with cell-free DNA. So I will move on to the results. And as you can see, we luckily met our primary endpoint. And in the intervention group, where biopsy was performed, basically whenever cell-free DNA was increased, the ABMR diagnosis was met earlier and with a median of 2.8 months, whereas in the control group, it was met after around 14.5 months. Of course, we had some delays because we have to acknowledge that the timing was imperfect. We had to do this trial during the COVID pandemic, so we had a bit of delay, but we also performed a sensitivity analysis. What if timing was perfect, and the time point the endpoint was still met. So on B, you can see the individual courses of the patients, and the first black arrow indicates basically the first time point where cell-free DNA was increased, and where the line ends is practically the biopsy-proven diagnosis. I would like to show you very briefly also the secondary endpoints, where we compared, similar as in other studies, the diagnostic metrics of the novel biomarker and the traditional biomarkers. So here you can see that this longitudinal cell-free DNA monitoring reached a good sensitivity and specificity around 80%, which is in line with previous research, and the positive predictive value in this selected cohort was maybe higher than other studies, was around 80% again. And the best metric was the negative predictive value, which is practically telling us that the biomarker is good to exclude AMR in stable DSA patients. And the prevalence among this group, the ABMR prevalence was 46%, which is, I think, also in line with previous research. So just to give you the impression about how traditional biomarkers performed, so here basically, if we would have used the creatinine course to tell if a DSA positive patient has ABMR or not, it would equal a coin toss, because the positive predictive value was below 50%, and it was similar also for the proteinuria, or the urine albumin creatinine ratio, which performs equally good or equally bad, as you would like to label it. Another aspect of our study, we had the chance, as I mentioned before, to perform molecular diagnostics at the time of biopsy for all patients in the intervention or control group. So as you can see, we did a correlation analysis, and the cell-free DNA release practically correlated very good with microvascular inflammation and conventional histology, but it correlated even better with the molecular transcripts in MMDX that were indicating an active ABMR, which again supports also the data of Dr. Aubert before, that the biomarker can really reflect some injury and active course of disease. So I would like to conclude with our beautiful graphical abstract. In the NDT journal, our study was published there last year, and yes, the conclusion and the key message of our trial is that this biomarker can really be of added benefits, and the selected patients with high risk for ABMR, which is in our case only patients with de novo DSA, but you can also use it for DSA pre-existing or de novo or both. And again, the conclusion is that this longitudinal monitoring and the cell-free DNA guided biopsy can reduce time to diagnosis of ABMR and maybe help expedite some therapy initiation, as we now have novel drugs upcoming. So this was our key message, and I would like to thank the whole team here who supported me to do this work. And I have one additional slide. I know that I have to keep it short, but since I was invited to join the Tour de France Académique, I wanted to give this take-home message, or just maybe to go into the discussion which is following. I think it's important in Tour de France, the real one, and also Académique, that we have to make sure we have mapped the route before hitting the road. And I think it also applies to the implementation of novel biomarkers, such as the cell-free DNA or also the chemokines, like Dr. Aubert showed. And yes, I think to map the route is maybe to think about the clinical context that we will use the biomarkers. And I have the small animation here. So I just replaced like the trees and the rivers with some DSA and rejection episodes. And the hills might be some creatinine rises that are sometimes very relevant, as you might know. So thank you
very much. And before starting a mountain stage of the Tour de France, make sure you are able to go uphill around your house, first of all. Well, thanks for both your very interesting presentations. I have a first question, possibly for you, Aylin. Apropos the cell-free DNA, it's increased in a variety of conditions. Olivier has shown us this. My question is, which is the main source of cell-free DNA in the patient with donor-derived, of course? Which type of cell? Can it be any type of cell within the kidney or not? And the following part is the endothelial cells. These are the cells that are most in contact with the blood. And are these 100% derived from the donor, or is there a sort of homing of cells from the recipient, which changes the phenotype of these cells, and which could, with time, change the amount of cell derived from the donor in the context of humoral rejection? This is a theoretical concern. I'm not a specialist of transplant.
Yeah, thank you for your question. I have been asking myself the same question now that I'm doing 3 years of research on cell-free DNA. I think it's very interesting to also answer this question about the background of release, because at the end we have to be familiar with this to keep an eye on some factors that might influence the release when we're treating the patients, because also what is a bit, it was too focused. In my opinion, cell-free DNA was deemed as a rejection biomarker early on. So I think in the last 2 years, we started to talk about it as an injury biomarker. So first, we all know it's a non-specific biomarker, and release can be due to any, I think, injury which happens in the microvascular compartment of the kidney. And like an approach that we can do, we also did another study to build on what we did in the RCT with like maybe 160 biopsies, and Aubert of course has a lot more biopsies in the Nature Medicine paper. Like the basic approach was to correlate the release with the Banff scores. So I think in most papers, the same state holds that the main trigger for the release is microvascular injury. So it would be any injury in the glomerulus and in PTC, like in peritubular capillaries. And on the cellular level, I think it is endothelial cells. Also in the research works of Dr. Halloran, who are doing the molecular the MMDX and cell-free DNA studies, in the trifecta study, they have proven this. What we do, which is maybe different from the others, is that we use another method of quantification, where we get the cell-free DNA reports with the donor-derived cell-free DNA reported in fraction, like how many of the total cell-free DNA in the recipient's body is coming from the donor first. And we also have it in copies. And another third report we have is the total recipient DNA, which can vary. For example, your own cell-free DNA can also be increased in high cell turnover, in malignancies, and infections. So we noticed some noise in viral infections, for example. And I think this is quite relevant because kidney transplant recipients do have to deal with a lot of problems, and it's not only about rejection. So we kept an eye on it, and we will look how it can influence the cell-free DNA of the donor. But in our experience, it is better if you use the fraction and also the copies, because the fraction can get, it's basically depends on the total recipient DNA. Okay. So maybe it's not the best case to rely on it if you have another condition like viral infection or malignancy.
Okay, thanks. Olivier, do you want to comment on this?
Yes, so I think it's a very interesting question because we were very surprised that cell-free DNA is not increased in case of BK virus-associated nephropathy. And so some publications, so they showed that, but it wasn't the case in our cohort, but also in the US. And so in clinical practice, I mean, there is no elevation of cell-free DNA when you have BK virus-associated nephropathy. And as you said before, it's because there is no microvascular inflammation. And so this is why I think it's increased in case of ABMR. And you can see some TCMR where you have very low or not very elevated donor-derived cell-free DNA, but it's elevated when you have also protubular capillarities. So I think that the cell-free DNA is only increased, as we said before, when you have microvascular inflammation. And I think this is why it's not increased in case of BK virus-associated nephropathy. So it's a good marker of ABMR. It's good for TCMR, but I think that it's always the best for ABMR compared, for example, for chemokines, which is increased in case of TCMR, and sometimes it fails when you have ABMR.
So if ever we have a BK virus, a patient with BK virus, and we reduce the immunosuppression, could it be useful to monitor the patient? So we monitor the BK virus viral load, of course, creatinine and so on. Could it be useful to see whether there may be a T cell rejection within the evolution with the reduction of the immunosuppression or not?
So this is what we do. So when we make a minimization in case of BK virus associated nephropathy, so we use both chemokines and cell-free DNA, because you can see that chemokines are very elevated in case of BK virus associated nephropathy. You can see that it's decreasing, but then sometimes it increases again, or we do cell-free DNA, it's increased, and we perform the biopsy. I have one patient, so I made the biopsy based on the chemokines and cell-free DNA, and then he had TCMR, so we had to treat the patient. So I think it's a good tool to monitor the patient also after treatment.
Okay, so thanks for this. And in terms of monitoring, with patients with chronic ABMR, where you know there is a microvascular inflammation, you use the treatments you can because there's nothing very spectacular for the moment. Do you use it to monitor the activity within the kidney, or in addition to the kidney biopsy, or not? Once you have the diagnosis and you've decided the strategy, do you think it's only possible to rely on the kidney biopsy, or can this be useful?
So based on the publication, with the new CD38 treatment, the farzatamab from the group from Austria. So they show that when you have chronic active ABMR, when you treat the patient, you can see the cell-free DNA decreasing. And so this is what we do now. So when we want to treat patients for chronic active ABMR, we use the daratumumab. So we try it. So we perform cell-free DNA the first day of the treatment, then at 2 weeks, then at 1 month, to monitor the decrease of cell-free DNA. And then we can avoid the biopsy, because then if we do a biopsy, so if there is still chronic active ABMR, we don't have any treatment. So obviously, so we don't want to make another biopsy, but then we can see if the treatment is working based on the biomarker.
Okay, very good.
I can add to this, maybe we are quite doing the same, or we did participate in the felzartamab trial with Austria. We were the second center, and now we are doing an extension trial of the patients that get the drug for another year practically. So there we also included, even as Olivier explained, a cell-free DNA guided treatment phase. Because in the felzartamab trial, in the phase 2 trial, we noticed that the cell-free DNA comes back with the relapse. I think it's a bit delayed. I would suppose that the moleculars, like if you do an invasive biomarker, an MMDX, you'd catch the relapse at its earliest stage. I think cell-free DNA is a bit delayed response, but still it can mirror the relapse of ABMR activity. And the idea is practically, if we use an effective therapy, of course, like the felzartamab or daratumumab, that we could guide treatment and give an on-demand dosing to the patients without maybe doing a biopsy. So you could potentially avoid follow-up biopsies to see a treatment success, or to again assess a treatment requiring relapse. I think those are the two potential use cases.
Although this is promising, the evidence is not very, very high, and you don't know when you're supposed to stop the treatment or should you continue or not. So of course it can be useful. You were talking about the transcriptomics and the BHOT panel. Just before talking about the uptake of all these strategies, how do you choose a panel for the transcriptomics on the biopsy? Because I mean, how was the BHOT panel chosen? Why was this chosen? There are so many potential candidates we could choose. We could reduce the panel to be nearly as effective and less expensive. I mean, how would you advise people to choose a panel? Because of course you need evidence. This is the most critical part.
Yes, I mean, it was a consensus from the Berndt group. So what they did, they looked at all the literature and all the results using transcriptomics before, such as the MMDX and other studies. And then they selected a number of transcripts. Obviously, 700, I mean, that's too many. And so that's why for the AMR classifier, we only use 52 genes, and for a TCMR, 15 genes. But then, so what I think is that we can improve then the classifiers with new, maybe transcripts. And so this is the next step, then using the data from the NGS, for example. So we performed a study where we looked at the association of different genes from the NGS with the comparison of MMDX, but also the nanostring. And I think that using those discovery platform, you can discover new genes. So I think this is the main issue of the nanostring and the BHOT panel. It's not a discovery panel. It's just a panel that you can use to make the diagnosis. But then with other platforms such as MMDX from Edmonton or also NGS, you can improve maybe the genes that have been selected. Okay,
so now we've been talking about 3 different techniques at different steps of the categorization of the patient's rejection. All kidney transplant centers do not use these 3 techniques. Some even use none of them. This is a European webinar. Could one of you just give us an overview of what the percentage of centers using one or all of these techniques is in the different countries in Europe? Because, of course, you are both from very expert centers, but some centers do not want to use it and some do not have the possibility to use it. What's the real life in Europe?
That's a tough question, but I will say, like, in real life, I mean, very few centers use the transcriptomics. First, NGS, too expensive. And then you need also to have an extra core. So NGS is just for research. So nobody will use it in clinical practice. Then you have MMDX. This is from Edmonton. So you need to send the biopsy. So I would say that for clinical practice in Europe, nobody use it. And then nanostring, so I know you have different platforms, but so far for clinical practice, I would say it's just research. So for example, in France or in other countries, they just perform it just to see the association. Nobody will take a decision based on this. And so it's just for research. But I don't know a team in Europe that uses in clinical practice, but maybe you have other data, but I don't know.
What about cell-free DNA and the chemokines then? This is maybe for Aylin, I don't know.
Yes, so for MMDX first, we tried, there are 2 European centers now that offer the MMDS diagnostic. The one is in Prague and Czech Republic, and the other one just was launched just last year in Vienna. However, it still remains a service that the insurance companies has to pay, because our center got familiar with the MMDX, like the most European centers that know it, due to study participation. We were just part of trifecta or multicentric trials, so this is how we maybe get to know the test a bit and get familiar how to work with this. But we now tried, since the trials are not recruiting anymore, to do it. We have to do a reimbursement, to write a reimbursement letter to the insurance companies, for example. We just wanted to try if it works, and in cases where we have an unclear histology. And it is very hard. This is the clinical reality, because this is not a familiar test, and they require some certificates, and it is expensive. It's around 3,000 euros or something. So we had several cases where we had success, but I think if only few centers are trying to do this, it will be very hard. And this was with MMDX, with cell-free DNA. We're currently doing this in high-risk patients or in patients to guide AMR treatment with anti-CD38. But we still only perform this for our patients who were participating in the studies. So I think it's in Europe, it's not that established like in the US, and the companies are not familiar with our projects, I think.
Can I add something just to say that I think the issue with donor-derived cell-free DNA, it's very expensive. In the US, it's reimbursed, but it's 2,700 euros. So it's more expensive than a biopsy in Europe. So I think it's easier to perform a biopsy. And so in France and in other countries such as Spain, so we are trying to get the reimbursement because it's very expensive. Once again, for the chemokines, it's 5 euros. So it's very easy, it's cheap, so the hospital can pay for it.
Thank you. The last question for me. We have now quite a lot of tools, and this is improving a better way to characterize the rejection. But to take the decision not just to know whether or not we have to do a biopsy, but to take the decision to treat the patient, there's the other side, which is the immunosuppression, how immunosuppressed the patient is with tools like the TTV, viral load, or ongoing things maybe I do not know. How do you think this is going to evolve? This is especially for Olivier, since he's working in the artificial intelligence world. Do you think we're going to have integrated tools which will take the balance between the risk of the treatment and the characterization of the benefit based on all these different parameters you've described here, which will help us to decide whether or not a patient has to be treated, how strong it has to be? We're talking about anti-CD38 treatments. These are very, very strong treatments. Do you think this is going to be one of the perspectives, or it will still be patient by patient for the clinician? How do you see the future for this?
I think, this is the real question, because now I think the big issue is that when you have the results from the transcriptomics, let's say you have a patient just G1, and then you have ABMR. So would you treat the patient? So I think this is the big issue, because the cutoff for ABMR is high. It's also because we don't want to treat all the patients. So I think this is the first issue. So we need to balance the risk of infection and death, but also rejection. So I think that the next step is to integrate other biomarkers. And so like TTV, we don't have the experience in France, so we are trying to use it in different protocols. So I think it can be integrated. But I think this is the goal, but also other biomarkers that can help you to predict infection, such as, for example, the thymic function. And so other biomarkers needs to be in addition to those biomarkers, because I think that using all the new tools that we have, we will overtreat the patients. And this is the main issue that we will face, especially with cell-free MMDX, because it's always elevated when you have a DSA, so it's very difficult. So next step, we need to integrate new biomarkers that can help us maybe to balance the treatment, because this is a big, big issue.
Thank you.
I have 2 or 3 final questions, and I'm no longer in transplant nephrology for 7 years or so, and to me it looks as if it gets ever more complicated. Anyway, to allow understanding for non-transplant experts, if I go back to the units you use, so we have the Berlin way of reporting, which was focused upon units per microliter or milliliter, and we have the percentage which has been published in your Nature Medicine paper and other papers. I understand this units per milliliter. For the percentage, this would mean if you report 2%, then among 100 DNA fragments that you find in a certain amount of plasma, 2 of these 100 would come from the donor, or as the lab apparently only knows the HLA, 2% of these refer to the HLAs, which can be traced back to the donor. Did I get that right?
There's the ratio, so you have the total, so donor plus recipient, and then you have from the donor, this is just a ratio, so it's 2%, so it means that you have 2 out of 100 from the donor.
And the
From the recipient,
98,
sorry.
and the 98%
98 from the
are from the recipient. But again, this can only refer to a certain peptide or protein, because the lab would have to know which DNA to look for.
Yes, in our case, it's determined, like it's built on genetic differences between the donor and the recipient. So we cannot do this, I think, for example, monozygotic twin transplants. We cannot perform this diagnostic there, because our lab always does this in the first measurement for a patient. They try to identify the SNPs, the single nucleotide polymorphisms between donor and recipient, but they can only do this from the recipient's blood sample. So this is how they work.
Yes. We use the SNPs, and we say that the one that is the most increased is from the recipient. The lower one is from the donor, but we don't do genotyping. And so this is why you cannot use it when you have a combined transplantation, let's say, for example, heart and kidney or liver and kidney. They're working on a test that can differentiate 3 different genotypes, but it's not available right now.
So you don't tell them before the HLA of the donor. They just compare the, say, HLA A or B or the R whatsoever, and find that the majority comes from, say, HLA2, and there's a small fragment A3, and this then should come from the donor. Did I get that correctly?
Yeah, I think it's unlike the DSA. This is more for the case of how to detect donor-specific antibodies. I think it's the way that works. But I think for the cell-free DNA, as they work with much less smaller molecules, they can really do it based on SNPs. And for example, our lab uses the PCR-based method. It's a droplet digital PCR. And this is how they work. And it's a targeted way to detect the SNPs. And I think in NGS, Dr. Aubert knows much better because they use the NGS-based assay. You have like a shotgun PCR or methods that work differently, but I think the background is the same, just to see based on the SNPs, what are the differences, so you can identify the donor fraction of DNA.
Thank you. And 2 final questions on your Berlin study. So with regard to the primary endpoint, why did you only include antibody-mediated rejection and not both antibody-mediated and T-cell rejection? And the second question, since you did the measurements each 2nd or 3rd month, so I think if I got it right, 6 measurements per year, how is the variation for a given patient? So I think half of all patients had elevated results at a single time point, but how often does this occur at various time points? And if you would have measurements even more frequently, might even more patients have positive results?
To the first question, as we conducted the study, I think it was in 2020, where the DART study just came up, and it was in the very beginning, let's say. So I think it was very clear that this test performs best for ABMR. So we just tried to translate this great performance into clinical practice and see, does it really matter for kidney transplant doctors now and for patients? So that's why we decided to conduct the study in the selected population. And when you only select patients with donor-specific antibodies, we had a high pretest probability for ABMR. So this was what we looked for. For the TCMR question, we would, of course, include TCMR in any way in the analysis if we had one, but we had none. I think there are 2 explanations for it. Our cohort was It consisted of patients that were in the later post-transplant phase. And as we all know, TCMR is rather an early event occurring in the first months or first year post-transplant. And we also had, I think for the majority of patients, 23 out of 26 biopsies also had an MMDX. And our TCMR score was 0 for all this. So we had no TCMR, which of course is not really convenient, maybe, so we cannot judge the performance on TCMR, but we didn't, like, we really wanted to focus on the dynamics in ABMR. And about the second question, if this baseline really varies, I think it's a good question, but I think, well, to the background, the test is actually very, the cell-free DNA in blood has a short half time. So I think it's a good question, and this is something we should keep in mind if we do this. That's why, for example, the release can be rapid after some mechanistic injury or a biopsy, let's say. I think that's why they do not recommend a cell-free DNA assessment, I think, up to 48 hours after a biopsy. So we have to keep this in mind when we do the measurements. And in my experience, if we would have done it more often, I think we wouldn't see big differences, because this is a parameter that comes from a certain tissue. It's the kidney. And we also did a lot of real-world measurements where the indication came not in the study, but in other experience, where the indication was, let's say, transient creatinine rise due to some hypertension or hypotension or proteinuria, and we noticed that cell-free DNA is not increased in any, let's say, small dynamic. I think it's the baseline is realistic, let's say, and it really mirrors an injury in the kidney or not.
Well, thank you very much. Thank you to both of you. And this is the tour académique. And one of the fun parts of this tour académique is that we invite the local presenter to share a few slides on his town. So, Olivier, you're from Paris, of course. People know Paris since it's located in the suburbs of Rouen. I'd like you to share a few slides to see what you specifically like in Paris.
Yes, I want it to be original, but it's very difficult not to start with this one. The Eiffel Tower, I guess. So, because this is probably the, most amazing part of Paris. So yes, the first one is the Eiffel Tower. I just have 3 different places. So this one, you know it. Then the second one, I would say Montmartre. And with the Sacré-Cœur, I think Montmartre is the place that I love the most in Paris. It's because it looks like a small village. And so this is the best part, because we have lots of different areas where it's crowded, big buildings. And so this is perfect because you can have a glass of wine at the end of the day with your friends. So I love this place. And the last one would be l'Île de la Cité. I think this is the most expensive part of Paris, so I won't be able to buy an apartment there. But I love this area because you can walk by the river, La Seine, and also you have the cathedral. So I know now the cathedral is not perfect, but it's going to be very fast. And then we'll have, again, our cathedral. But I love this area where you can walk. You can have also a bottle of wine. You can drink with your friends. So I think this is one of the best places in Paris.
No, thanks for sharing. Just walk around Paris. Forget the metro, the U-Bahn. Just walking, you can see beautiful places like this.
Exactly, yes.
Thank you very much, Robert. Thanks to both of you.
Thank
Bye-bye.
you.
Thank you.